Hello and welcome to MedEd's production of Nursing Excellence Training. My name is Lisa Soltis and I'll be your instructor. The title of this module is Shock States. So we will be discussing the various components of shock states and describing what's happening at the cellular level. Our objectives for this lecture then is to describe the pathophysiology associated with various shock states, to discuss the hemodynamic findings and variations that we see between the different types of shock states, and review the basic components of oxygen delivery and oxygen extraction and how we can monitor that. So what is shock? Shock, by definition, is the inability of the circulatory system to provide adequate oxygenation and perfusion to the tissues. It's more than just a decreased blood pressure or low blood pressure. Sometimes people define it as, just the blood pressure part, but truly shock is a cellular phenomenon. The cells aren't getting oxygen, and without oxygen, then they move into anaerobic metabolism. The byproduct of anaerobic metabolism then is lactic acid. And obviously that is less than ideal for the tissues. It's less effective for anaerobic metabolism, and lactic acid is toxic to the body. So they get widespread impairment of cellular function and metabolism because of the lack of oxygen. That causes damage to the tissues, that causes damage to the organ overall, and if it's not corrected in a timely fashion, then obviously it can lead to death. In adults, many times they look at just that blood pressure component, so the systolic pressure less than 90 or a MAP less than 60, but really a better definition would be to look at least a 40 millimeter of mercury drop from their baseline pressure. So again, it doesn't necessarily mean it's just a blood pressure. It means they're truly not perfusing at the cellular level, and the MAP is a good overall indicator of their overall perfusion status. There are three universal conditions associated with any shock state. Obviously, the first is that they're hypoperfused. So again, at the cellular level, at the tissue extraction level, there is not enough perfusion to support oxygenation and the ability to drop off of hemoglobin to drop off oxygen at the tissues so that they can have that oxygen available. When we don't have good perfusion, that's going to activate the inflammatory response, and we'll talk about the ramifications of that. And part of the inflammatory response is also activation of the coagulation cascade and activation of our platelets, and so that will put them in a hypercoagulable state. So we'll talk about the importance of monitoring platelets, as well as the importance of the fact that they are more prone to developing clots, and that can further impair tissue perfusion. There are various stages of shock, and I know in previous modules we had talked about the compensatory mechanisms of the body and how important it is for the body to try and maintain normal perfusion. In the initial stage of shock, the tissues are already underperfused, so they're not getting the oxygen that they need. Typically, we'll see a decreased cardiac output in most cases. We'll see an increase in that anaerobic metabolism, and obviously that's going to create lactic acid and create a metabolic acidosis as a result of that. The challenge in the initial stages of shock is that the patient will look completely normal. And so it's under the radar, and unless you're really looking closely and fine-tuning their vital signs and their labs and things like that, it can very easily be missed, and people can compensate for a fair amount of time without us realizing that at the tissue level they're really underperfused. So looking at this diagram that you have on your screen there, looking at our systolic blood pressure, it's still going to be relatively normal. It's not till after we're farther into the initial stages of shock that we may see that systolic pressure start to decrease. As our blood pressure decreases, then our body will try to compensate and increase the heart rate. So it's not till the very end of the initial stages that we'll start to see the pulse start to creep up. The bicarb was not going to drop dramatically, but it is going to kind of slowly decrease. Normal bicarb levels are 22 to 26. So we may see it, if they normally are at around 25, by the end of that initial stage, they may be at 22, 21, where it's just slowly starting to drop down to the lower end of normal. And the lactic acid is fairly stable at this point. So maybe a tiny increase, but not a significant change. The next stage of shock then is the compensatory stage. So this is where the compensatory mechanisms kick in. If we identify shock at this stage, then it is completely reversible so that we can support their oxygenation and support perfusion, and we can completely reverse it, and patients will have no long-term consequences associated with that. The sympathetic nervous system is now activated. So we have a decreased cardiac output, decreased perfusion, and so that will signal to the sympathetic nervous system to tell the adrenals to release epi and norepi. Those are designed to increase our heart rate, increase contractility, increase our stroke volume, and try and support perfusion that way. So again, we'll see those mechanisms kicking in to compensate for that decreased perfusion. What that looks like then clinically is now we're starting to see the blood pressure, which is the purple line, and you see the blood pressure starting to continue to descend, and now it's getting close to the 100 millimeters of mercury point as far as the systolic pressures. We'll see a significant increase in the heart rate. So again, epi and norepi is telling the heart to beat, harder, faster, stronger, try and get that heart pumping and try and support perfusion. So you'll see that increase in contractility and increase in heart rate during the compensatory phase. So now many times heart rate is close to 100 if it's not over 100. Our bicarb levels are going to start to really drop now. So now we're noticing the bicarb is, right around 20. So it's, it's slowly descended, and now we're outside of the normal range for the bicarb level with that. And our lactic acid still at this point is fairly stable. So it's still within normal limits and not a concern at this point yet. But unless we're looking for shock, again, the compensatory stage is really the most difficult stage because we may not even notice that the patient, these slight changes in their vital signs are occurring unless we're really looking for it. The progressive stage then is the next stage, and this is where the compensatory mechanisms start to fail. So now we'll see with that continuous activation of the renin-angiotensin-aldosterone cycle, the continuous sympathetic nervous system activation, all of those are inducing vasoconstriction, and the natural process for the body is during shock states through the process of autoregulation, the body's going to clamp down out in the periphery, and it's going to divert the blood back to the core and back to the top three, which is our head, our heart, and our lungs. Those are the priority organs, and so the body clamps down in the periphery, diverting the blood back to the core. So our liver, the kidneys, any of our, the GI tract, any of our internal organs then, typically then will also have decreased perfusion because the blood is being diverted to the big three that we need to make sure we support perfusion with that. So we get this profound vasoconstriction out in the periphery, and the challenge there is when the vessels are clamped down, then that's going to lead to profound ischemia. And when we have very low levels of oxygen and ischemia, that's when we see the lactic acid start to go through the roof. And so the production of lactic acid goes up significantly during this progressive stage. And so now they'll have a much more profound metabolic acidosis as a result. So following our diagram through, now we see the heart rate is much higher than it should be, and so well over 110, 120. We see our systolic blood pressure now is again starting to become more compromised, and so typically systolic pressures are below 100 at this point. Our bicarb is below normal, so it's much less than 20, 22, much less than that. And now our lactic acid is starting to climb. And so now we'll start to see the lactic acid moving up towards 2.0 milliequivalents or millimoles, depending on how it's reported in your institution. And so we'll start to see those lactic acid levels start to climb as a result. The refractory stage then is where things can be irreversible. So now all of the compensatory mechanisms have started to fail. At the cellular level, we're having cellular necrosis and tissue death, which leads to overall organ failure, depending on the tissue that they're looking at. So then they move into that multi-organ dysfunction syndrome or multi-system organ failure. The new term is the multi-organ dysfunction syndrome. Other challenges is that, again, part of the inflammatory response, as I said, will activate part of our coagulation cascade. And so through the clotting process, we'll start these tiny clots at the microcirculatory level, which then creates a consumptive coagulopathy. So we start to use up all of our clotting factors. When the body realizes it doesn't need those clots, it'll try to break down the clots, the byproduct of which is then these fibrin degradation products or fibrin split products. And those split products then have anticoagulant properties. And so that's what kind of leads up into the development of DIC, or disseminated intravascular coagulopathy. So we'll start to see the platelets are dropping, they're using up their clotting factors, we start to see signs of thrombosis, and then they move into the hemorrhagic phase if they do develop a full-blown DIC picture. So now you see as our trends have progressed, heart rate significantly elevated, blood pressure is significantly low, bicarb is well below 15, lactic acid is now climbing beyond 4, indicating they're in a severe shock state. The last phase of shock then is where everything just completely fails. So then the heart can't maintain a heart rate in the 140s, 150s, the blood pressure is very low, bicarb dropping, lactic acid is climbing, and so usually patients cannot survive once it moves into this refractory stage. So the challenge is really looking for it, if we can identify it in the initial stages or the compensatory stage, has the best chance of survival and best chance of complete reversible, and being able to restore perfusion and make sure that the patient doesn't have any long-term damage to their organs. So the compensatory mechanisms that we described, we have these, the neural response is that we have these baroreceptors. Baro refers to pressure. So we have these pressure receptors in the aortic arch and the carotid bodies, and they pick up on changes in our mean arterial pressure, changes in our cardiac output, and they're very volume sensitive. And so if they detect that there's a decrease in cardiac output or a decrease in circulating volume, then they will activate the vasomotor center of the medulla. That's what activates then the sympathetic nervous system, and so then that kicks in, tells the adrenals to release epi and norepi, and so we see that increase in production of those catecholamines. The adrenal corticotropin hormone is also released to help activate the hypothalamic pituitary axis as well, and adrenal axis as well. And then we have activation of the renin-angiotensin-aldosterone cycle is all being activated in response to this decrease in pressure or decrease in volume. So the main components of the neuroendocrine system in response to stress. As we mentioned, the sympathetic nervous system is the initial phase or the initial response to the stressor or the decreased perfusion pressure. And as we said, epi and norepi are the stress catecholamines designed to increase our heart rate, increase contractility, and also increase our vascular tone. The second component then is the renin-angiotensin-aldosterone cycle, and we'll talk about that next. And then the hypothalamic pituitary adrenal axis, where the pituitary gland increases the production of antidiuretic hormone, which helps us hold on to fluid. The kidneys hold on to more fluid, increasing our preload and volume. And the adrenal cortex will release cortisol, and cortisol is very important in maintaining our myocardial contractility as well as our vascular tone. That initial sympathetic response then is the body's attempt to maintain normal stroke volume and normal blood pressure. Initially, you'll see an increase in cardiac output and cardiac index to try and compensate. You'll see an increase in heart rate. So remember that diagram of those, the compensatory phase. So eventually, it'll help for momentarily getting our cardiac output and our pressure up. But unless we fix the cause of the hypoperfusion, then we'll start to see it move into the progressive stage and eventually into the refractory stage with that. The longer that those compensatory mechanisms are activated, then the higher our systemic vascular resistance becomes. We start to clamp down. Now the heart is working harder and it's pumping against a brick wall because of that autoregulation process. The body's squeezing the blood back to the heart, to the head, and the lungs. And so out in the periphery, then you'll see it move into that progressive stage. The renin-angiotensin-aldosterone cycle or system is also an important part of the compensatory phase. Renin is secreted by the juxtaglomerular cells within the nephron in response to sympathetic stimulation as well as in response to decreased blood flow. I know you've heard me say before that the kidneys are very sensitive to changes in pressure, changes in volume, and changes in cardiac output. So I break it down to either a pump, a pressure, or a volume problem. And so they're kind of like the poor man's cardiac output monitor, because if our urine output drops off and their kidneys aren't functioning normally, then that usually indicates that our cardiac output has been compromised, whether it's a volume problem, a pressure problem, or a pump problem. So I know this slide has a lot on it, but it's important to understand the effects of that decreased perfusion to the kidneys. So if you start on the left-hand side of the page, you see the kidney on the lower half of the screen, and when it is not perfused, as we said, those juxtaglomerular cells will then secrete renin. Renin then tells angiotensinogen in the liver to become angiotensin 1. Angiotensin 1 then moves to the lungs and is converted to angiotensin 2. Angiotensin 2 is a potent vasoconstrictor, so again designed to increase our vascular tone and increase our overall mean arterial pressure. Now the other interesting thing about angiotensin 2 is the presence of angiotensin 2 in our body will also stimulate the adrenal cortex to release aldosterone. Aldosterone is a mineralocorticoid that tells the kidneys to reabsorb sodium back into circulation. And where sodium goes, water follows. So we reabsorb sodium back into circulation, and water that was initially filtered out as urine, or to eventually be urine, will actually get reabsorbed back into circulation again. So that increases our preload. So we have more volume within the vascular compartment, so the kidneys hold on to fluid. One of my textbooks said the lack of urine output in a hypovolemic patient is actually renal success, not renal failure, because the kidneys know the body is compromised and the body needs to hold on to that fluid. The presence of angiotensin 2 then also stimulates additional sympathetic stimulation. So again, more epi and norepi are released as a result of that. We get the vasoconstriction, we get the release of aldosterone. It also helps stimulate the posterior pituitary for the release of that antidiuretic hormone that we just discussed. The hypothalamic pituitary axis, again, cortisol is released by our adrenal glands, and that is extremely important for our vascular tone as well as our myocardial contractility. Vasopressin, our antidiuretic hormone, is also secreted by the posterior pituitary, working on the renal tubules to cause more volume and fluid to go back into circulation. So vasopressin, or antidiuretic hormone, is released not only with the sympathetic stimulation, but also when we have hypovolemia, so anytime that there's decreased volume within the circulatory system, when we have hypotension and our mean arterial pressure is low, when we have decreased right ventricular filling, and also when we have a high serum osmolality. When our serum osmolality increases, that indicates that we're dehydrated. We have a higher concentration of solutes within the blood, so they become hemoconcentrated, and that will also stimulate the release of antidiuretic hormone. So we hold on to more fluid, and that helps dilute the blood into a normal osmolality range. Normal serum osmolality is 275 to 295. As I mentioned then, antidiuretic hormone works on those renal tubules and causes the kidney to reabsorb more water back into circulation. So less water is actually allowed to form urine, so the urine becomes very small amounts and becomes very concentrated. We also know that in prolonged shock states, as these vasopressin is continued to be secreted then by the pituitary, that if our blood volume continues to drop, then it activates V1 receptors within the vascular smooth muscles, and then it can act as a vasopressor to help increase our vascular tone as well. Sometimes we can see an increase of that antidiuretic hormone and the secretion of it to more than 50% of their normal levels to help us maintain a normal blood pressure in prolonged shock states. So bottom line with shock, things that we need to be looking for to determine or pick up on that our patient isn't perfusing at the cellular level. The first is a mental status change, so changes in their level of consciousness. Maybe they're a little bit more confused, maybe they're a little sleepy, maybe they just aren't as responsive as what we normally see, or they have trouble answering questions. There's lots of assessment tools to assess for their neurostatus. So again, just paying close attention to any subtle changes that you may see in their level of consciousness. The presence of oliguria, that indicates oliguria is when our urine output is less than 400 mLs in a 24-hour period. So it's important again to make sure that we look at the urine output. If we have a patient, with CAUDI initiatives, we're trying to get rid of the Foleys because it's better for patients. We want to minimize the risk of developing a healthcare-acquired infection. So we're trying to decrease the use of Foleys and make sure that those are only utilized when it's in the patient's best interest and not necessarily for nursing for that. So it's important that we know how much our patient is voiding, and if we've had a patient all day and it's 3 o'clock in the afternoon and they haven't voided yet, make sure that we get the patient to void so that you can see how much have they put out during your shift. Extremely important to monitor their urine output, and we want to make sure that we address it quickly if there is any type of compromise there. And the presence of lactic acidosis indicates, again, that the tissues are hyperperfused. We should not produce significant amounts of lactic acid. So when those numbers start to exceed 2.0 milliequivalents or millimoles, then that does indicate that there is hypoperfusion and anaerobic metabolism occurring somewhere within the body. So we all learned, back in school, our cardiac output is our heart rate times our stroke volume. And our stroke volume then is comprised of 3 things: our preload, our afterload, and our contractility. And whether you realize it or not, we manipulate these 3 parameters, or 4 parameters, if you include heart rate, every single day with every single patient that we take care of. I like to joke that in critical care we have the Goldilocks syndrome because we want everything to be just right. And so our heart rate, we don't want it too fast because then it's going to impact our diastolic fill and impact our stroke volume. Increases myocardial oxygen consumption significantly, and obviously that's detrimental to the heart. We also don't want it too slow because if it's too slow, then we don't have enough of a heart rate to help support an adequate cardiac output. So again, very important that the heart rate is just right. Our preload is historically our volume, and so again that helps improve our stroke volume. When patients have adequate preload, then they usually have adequate cardiac output. If they have decreased volume on board, then that usually results in a decreased stroke volume and decreased cardiac output. So volume management is a very important part of reversing shock states. Afterload is the resistance that the heart has to overcome to push the blood forward, and so it's inversely proportional to our cardiac output. If I have a high afterload indicating that we're clamped down and our systemic vascular resistance is very high, that usually results in a decreased cardiac output because the heart is trying to push really hard to pump that blood forward, and obviously all that resistance is going to push it back towards the heart again. It's also important to appreciate the fact that I have afterload on the right side of the heart, which is our pulmonary vascular resistance, and I have afterload on the left side of the heart, which is our systemic vascular resistance. If our afterload is low and the resistance is low, then usually you'll see a higher cardiac output to try and compensate because of the vasodilatation that's present. So again, our afterload has to be just right so that we have enough of a pressure gradient to have adequate oxygenation at the tissue level, and that we don't have too much that's going to increase cardiac workload and myocardial oxygen consumption. And then the last component is contractility. This is how hard the heart squeezes. So things that'll increase contractility, usually when you have an increase in those catecholamines, increase in the squeeze, and the heart's pumping harder and more effectively, then usually it will result in an increase in stroke volume and increased cardiac output. If we have a decreased contractility, so they have heart failure, acute MI, some sort of disorder or medication that we're giving that has decreased how well the heart squeezes, then typically that will result in a decrease in stroke volume and a decrease in cardiac output. So we manipulate these parameters all the time, and it's important to assess those components of their hemodynamics, of their overall perfusion state, to make sure that everything is adequate. Preload, as I said, is defined as the volume, basically, and it's the amount of stretch before systole with our cardiac fibers. Historically, we've measured it with CVP, or central venous pressure, and we've learned more in the literature about challenges with CVP monitoring. For decades, we have operated on the premise that pressure equals volume, and we now realize that's not always the case because it doesn't take into consideration as far as compliance and how compliant is that ventricle and the heart itself. So typically, if you remember Starling's law, or the Frank-Starling curve, discusses that if there's an increase in stretch or increase in volume, that you have a better ejection, better contractility, as long as the stretch is within those physiological limits. Now, one of the things, if you dust off your cellular physiology, because I know it's still in there, if you remember, our muscles are a series of actin and myosin fibers, and those fibers overlap. And when the muscle is stimulated to contract, or if it's in the case of the heart, where it's depolarized to cause the muscles to contract, those fibers pull together to shorten the muscle. So in the heart, if we have a little stretch, these are my actin and myosin fibers. So if I have a little stretch, little squeeze, little stretch, little squeeze. If I fill the ventricle more, so I get more volume within the ventricle, and now I get a bigger stretch, I get a bigger, stronger, more forceful contraction. So I need to make sure I have enough volume to help support that contractility, right? So little isn't enough, but too much is not good either. So now if I've overfilled it, and now some of my fibers don't even overlap because I've stretched that heart so much, so we see this with our reduced ejection fraction heart failure, or our systolic heart failure, where the ventricle is dilated and now half of my fibers don't overlap, and now I get a wimpy, puny squeeze because I've overstretched that muscle beyond its capacity. So again, everything has to be just right, that we've got enough volume to support contractility, but not so much that I've overstretched those fibers and now they can't squeeze together. So the bottom line with Starling's curve, or Starling's law, is that the larger our end diastolic volume, the stronger the contraction and the better the stroke volume that we will end up with. And so again, it's a very fine line that we try to balance between having enough volume to support that and not too much that we overload the heart. Afterload, as I said, is the resistance that the heart has to overcome for ventricular ejection. So now it needs to, what the heart has to overcome to push that blood forward. Typically, the higher the resistance, the higher the myocardial oxygen demand, and the higher the cardiac workload. Many times then, if our afterload is too low, we can look at adding vasopressor therapy and other pharmacological agents to help increase our perfusion pressure. But one critical factor that you always need to think about with any patient that has a low blood pressure is that we need to assess their volume status first. You need to give volume before you add squeeze. If we just put someone on a pressor such as Neo, it's going to squeeze down and clamp down out in the periphery, and it'll definitely bring up their mean arterial pressure. But if we don't have volume within those vessels, then we're going to be squeezing empty vessels out in the periphery, and then that means if they're empty and there's not good blood flow, then that means we have anaerobic metabolism and the production of lactic acid. And you can create a metabolic acidosis very quickly if you don't have adequate volume on board. Bottom line, our cardiovascular system is a bag. I have my heart, I have my arteries, and I have the veins bringing the blood back to the heart. And it's a closed system. There's a certain amount of volume within that system, and so we need to make sure we have adequate volume. So as I said, if I don't have enough circulating volume and we add a pressor or we start to clamp down through autoregulation and those vessels will squeeze, they're diverting that blood back to the core, and if there isn't enough volume within the circulatory system, we're squeezing empty vessels again out in the periphery and will create a metabolic acidosis. So again, always assess your preload and your volume first prior to adding a pressor, otherwise you'll create or worsen an existing metabolic acidosis. Contractility then, there's several different parameters that we can utilize to assess contractility. Typically stroke volume and stroke volume index are two of the more commonly utilized measures with that. Anytime you see the word index, so if it is a cardiac output versus cardiac index, stroke volume versus stroke volume index, anytime you index something, that means you take the number and you divide it by the patient's BSA. That takes the stroke volume and makes it specific to that patient's body size. So it's an important concept to understand, because that will, anytime you index anything, it's a better overall indicator of the cardiac output for that patient's particular size and body habitus. So if I have a cardiac output, and let's say I have Gladys over here, who's a friend of mine with 83-year-old, lives in a nursing home, and she is 5 foot nothing, and weighs about 110 pounds soaking wet, so tiny little thing, and she might have a cardiac output of 3.4 liters per minute, and you think, oh, that's not enough. But when I divide her cardiac output by her BSA to get her cardiac index, I will have a normal cardiac index. So for her cardiac output divided by her BSA will give her an index well over 2, which is normal. So it's important to understand cardiac index and the meaning of that. Over here I can have Mr. Jones, who's 6'7" and 350 pounds, and he has a cardiac output of 4.5. And we're thinking, oh yay, he's got a normal cardiac output. But when you divide it by his BSA, his index will be well below 2, which then indicates even though it's a normal cardiac output, it's not enough to support his body size. So index is extremely important to look at and understand when you're looking at these numbers. And there's obviously additional information in more detail when you look at the hemodynamics section of these modules. Left ventricular stroke work index then is also calculated, or right ventricular stroke work index can be utilized as well as far as assessing how well the heart is functioning related to contractility. So there's 4 basic subsets of shock, and the interesting thing with shock is it doesn't matter where you start, you always end up on the same road. So whatever the initial injury is that's causing them to have decreased perfusion is still going to activate those compensatory mechanisms and still put us in the compensatory phase if we don't identify it early and prevent it from moving into a shock state. The first is cardiogenic shock. So in this case, I have ineffective pumping of the heart. So I've got nice tight vessels, we have plenty of volume, but I have a problem with my pump. And so whether it's cardiogenic shock, acute MI, heart failure, myocarditis, anything that decreases the heart's ability to pump appropriately will cause a cardiogenic shock picture. The next we have is hypovolemic. So I've got a good pump, I've got nice tight vessels, but now I don't have enough circulating blood volume within the circulatory system that will support adequate perfusion, and so that will put them in the compensatory phase of shock. Distributive shock is interesting because I have usually distributive type shocks are pathological. Most commonly we see this with either neurogenic, septic shock, adrenal insufficiencies, different things like that, anaphylactic shock all fall into a distributive shock. With distributive shock, I've got a good pump. I have, circulating volume, but I have loosey-goosey vessels. So my vessels are all vasodilated, and that causes this maldistribution of blood volume. So the blood volume kind of camps out in the periphery, and because I don't have good vascular tone, it has trouble getting back to the heart, and it also causes then a decrease in our overall mean arterial pressure. Again, our MAP is what drives our overall perfusion, and so if the MAP is too high, heart is working hard. If our MAP is too low, then we don't have enough of a pressure gradient for the hemoglobin to be able to actually drop off the oxygen at the tissues. So my loosey-goosey vessels have a little bit of blood going through them, but it's not dropping off the oxygen because we don't have an adequate mean arterial pressure or pressure gradient for the tissues. And the last type is obstructive shock. With obstructive shock, then, I have a good pump, plenty of volume, nice tight vessels, but some sort of outward pressure is causing the heart to not pump effectively. So the heart's capable of pumping, but something is preventing it from being able to do that. Classic examples of that are a pericardial tamponade, if we have a tension pneumothorax, things like that where the heart is being compressed and it's not able to function normally because that increase in pressure. So the first we're going to talk about is hypovolemic shock. With hypovolemic shock, then, obviously good pump, nice tight vessels, not enough volume. So this can result from major trauma, any type of great vessel lacerations and significant blood loss from either blunt injuries or penetrating trauma with that, major burns where they just, when they lose that, the epithelial layer and then the body just starts weeping and they lose significant amounts of fluid through the interstitium that way, and so massive resuscitation is extremely important for those patients. Any type of GI losses, so nausea, vomiting, diarrhea, any type of excessive NG drainage, where they lose a lot of volume can certainly lead to a hypovolemic. And any type of massive diaphoresis, sometimes it's referred to as heat stroke, where they're dehydrated and they're unable to sweat like they normally do to cool the body, and so obviously can cause significant complications. So in this case, again, the loss of intravascular volume then is sensed by those baroreceptors in the aortic arch and carotid bodies and obviously activates that neuroendocrine system and response that we had described earlier. So the hemodynamic summary with a hypovolemic shock is that we have a decreased cardiac output and a decreased cardiac index. Our preload is decreased and our afterload typically is increased because the body, in response to the neuroendocrine system, is going to clamp down and try and divert whatever volume we have left within the circulatory system back to the core to help support the head, the heart, and the lungs. So in this table, I'm sure you've seen similar tables before, similar to this, and it talks about the classifications of hemorrhagic shock and talks about how much volume and classifying how much volume is lost and typically what type of signs and symptoms that we're going to see. And the reason that I point this out is that typically on any given day when you're taking care of your patient and let's say their heart rate is 104, do we usually get overly excited or twirled up when the heart rate's over 104? And most people will say, no, not really, that's not that bad, and so not really pay attention to it. Respiratory rate greater than 20, 24, possibly 26, most people again don't get overly excited about that and not really feel concerned about an increase in respiratory rate greater than 20. Pulse pressure is the difference between your systolic and your diastolic pressures. So you'll start to see that pulse pressure start to narrow, but unless you're really looking for it, you might not even notice that there's a slight difference in your pulse pressure where the difference starts to become smaller. Urine output, as I said, we're typically looking for 30 mLs an hour as it's kind of ingrained in school, and that's the number we kind of hang on to. Newer guidelines suggest that we use body weight as a guide, so half an ml per kg of body weight is a more accurate way of measuring urine output to make sure it's adequate, but for the most part, we will do whatever it takes to get that 30 an hour as far as, trying to work the Foley, making sure our patients have adequate urine output for that. And the reason I point that out is, a typical picture of a patient that has those signs, we typically would not get overly excited. But when you look at that in comparison to a patient that may be experiencing hemorrhagic shock, they've lost 1.5 liters of volume. So that's almost a whole Coke bottle, 2-liter Coke bottle. And all we're going to see is maybe their heart rate is a little bit faster, maybe their pulse pressure a little more narrow, respiratory rates over 20, and they still have fairly adequate urine output. And they've lost 30% of their circulating volume. It's not till they get to class 3 where they have lost 2 liters of volume that we start to see the compensatory mechanisms start to fail. So now their heart rate is significantly elevated, pulse pressure is narrow, systolic pressure is compromised, their respiratory rate is significantly elevated. That's absolutely fascinating to see that the body will do everything it can to maintain the appearance of normal in response to that hypovolemia. And so it's extremely important that we're looking for those changes. Another clinical note or clinical pearl that's important to remember is many times when we look at vital signs, we do pay attention to the heart rate, which is extremely important. Tachycardia is not normal. So if somebody's heart rate is over 100, we need to figure out why. Are they in pain? Are they anxious? Are they hypoxic? Is something else at play that's causing their heart rate to go over 100? And so we need to make sure that we investigate that. Additionally, it's important to pay attention to their respiratory rate. The significance of the respiratory rate, as the respiratory rate climbs, increasing the rate is going to increase how much carbon dioxide we blow off. So typically when somebody starts to have an increase in the respiratory rate or a tachypnea, it usually indicates they're already in a metabolic acidosis and the respiratory system's trying to compensate by blowing off CO2. So a fast respiratory rate is also extremely important to investigate and look into further, because it could indicate that they already have elevated levels of lactic acid from decreased perfusion and the body's trying to compensate for that. So do pay attention to your respiratory rate as well. So treatment for hypovolemic shock is to give them volume, right? So typically fluid resuscitation is the mainstay for this one. So again, any type of isotonic fluids, whether it's lactated ringers or normal saline, crystalloids are great because they're quick, they're fast, they're easy to give, not a lot of side effects, so you can very quickly volume resuscitate. Challenges with crystalloids, though, is that they don't have a lot of oncotic pull. So eventually, because of those inflammatory mediators in response to the shock states, that leads to the capillary leak, and then you start to see the volume leak from intravascular to interstitial. And after a couple of hours, only 250 mLs of the liter that you gave is actually still within the intravascular compartment. So again, if it's a patient who's hemorrhaging or a trauma patient, then we need to follow the ATLS guidelines. We need to make sure not only do we give volume, but we also give blood products. Typically for 2 liters of crystalloid to give at least 1 unit of packed cells. And after a couple units of packed cells, then you need to give a round of clotting factors. So, the packed red blood cells are only red blood cells, no clotting factors. So we need to make sure that we replenish that as well. Anytime you're giving lots of volume and anytime you're giving lots of blood products, you want to make sure that you monitor your electrolytes as well as your lactate levels, because that can also give you clues as far as are we adequately restoring perfusion at the cellular level. If the lactate level is decreasing, then that means we're perfusing the tissues better, and obviously that's a good sign. Cardiogenic shock is the next type. So in this case, I've got nice tight vessels, I have plenty of volume, but now I have a really bad pump, and that's why we're not perfusing. So we can see this anywhere between 8 to 15% of patients that have experienced an acute MI. We can see patients that have various types of heart failure can look like a cardiogenic shock picture. Any type of blunt trauma to the chest, all sorts of different things can lead to a cardiogenic shock. If they have valvular issues, if they have different defects, if they've had some sort of damage to the left ventricular wall, a rupture, myocarditis, any of those things can lead to a cardiogenic shock. When we look at the the clinical picture of a patient that's in cardiogenic shock, then the reason that they have inadequate tissue perfusion is because of the decreased cardiac function, and so again usually results in a decrease in left ventricular contractility, so less effective pumping and squeezing by that left ventricle. Most commonly, cardiogenic shock occurs after an acute MI, and patients that do go into a full-blown cardiogenic shock after a heart attack, then mortality can be as high as 67%. So extremely important that, again, we're looking for signs that the cardiac system is starting to fail with that. On autopsy, patients that have died of cardiogenic shock have demonstrated that there's been more than 40% loss of the left ventricular muscle, especially with a really large MI. If patients then, if we develop cardiogenic shock or they develop cardiogenic shock prior to percutaneous cardiac intervention, the mortality rate is almost 90%. So again, really early detection that the patient is starting to deteriorate is the key to survival. So with cardiogenic shock, we have alterations in our oxygen supply and our oxygen demand. If we have a decreased supply, so again it could be from vasospasm of the coronaries, decreased coronary perfusion, decreased blood oxygenation, if they have stenosis of one of the vessels or a thrombus, anything that decreases the ability to provide oxygen to the myocardial tissue will obviously decrease the supply of oxygen to the tissue. If we have an increase in myocardial oxygen demand, so now the heart is working harder and it needs more oxygen than it's capable of providing to it. So increase in heart rate, increase in contractility, increase in afterload, increase in left ventricular wall tension, the heart's working harder, using more oxygen, and if our oxygen supply can't meet the demand, then we end up with an oxygen debt. Again, that sympathetic nervous system is going to be the first component of compensation when we have decreased perfusion. So again, the hypotension, decreased cardiac output causes the release of epi and norepinephrine, and it works on those beta cells and beta receptors on the heart, telling it to squeeze harder, work faster, increase heart rate, increase vascular tone, and so obviously that's going to significantly increase cardiac workload the harder that it works. The body cannot differentiate between what is the stressor, and so the response is always the same, and in this case the effects can be devastating because now we're inundating the heart to work harder with all of these stress catecholamines, and it's the heart that's causing this problem to start with. So significant challenge there because the body's trying to help, but the heart isn't capable of rising to the challenge of being able to meet that need as far as adequate oxygen supply. The renin-angiotensin-aldosterone system that we've discussed, again, bottom line of that is that we have angiotensin II, which increases our vascular tone, increases our mean arterial pressure, so that increases our afterload. So now the heart is working harder, and now it's pumping against a brick wall because we're clamping down in response to the decreased perfusion. Our kidneys are saying, hey, I'm going to help, so I'm going to hold on to sodium, I'm going to hold on to water, because obviously we're not perfusing, we need more volume. And again, the heart is already overloaded, and now we've got it holding on to all of this volume, which obviously is going to significantly impact, again, cardiac workload and cause the heart to fail even more. So other pathophysiologic things, as we said, bottom line, the heart is inundated with these stress catecholamines. The kidneys are holding on to fluid. If we have patients then that have pre-existing either systolic dysfunction or diastolic dysfunction, again, management is going to vary as far as whether or not they need better squeeze or if they need better volume with that. And so very quickly, cardiogenic shock will turn into a heart failure, pulmonary edema type picture if we can't correct it. At the cellular level, again, remember shock is a cellular phenomenon, so that ischemia leading to the anaerobic metabolism, and that causes lactate buildup, causing intracellular acidosis. The myocyte pumps, the transport pumps, start to fail, and so the myocytes then, we start to see accumulation of sodium and calcium at the cellular level. Those myocytes swell and overstretch, and again it can lead to premature apoptosis, which is basically cellular suicide. So those cells swell, and so the normal gated pumps that help bring fluid out, and we have that influx and outflux of our various electrolytes. When those pumps fail, then it starts to fill with fluid, and then we end up then causing them to rupture, basically at the cellular level. The cell ruptures and they refer to that as apoptosis. If that cellular anaerobic or ischemia is severe, or if it's prolonged, then again it causes irreversible injury and necrosis of those myocytes. So if we have a patient with diastolic dysfunction, remember diastolic dysfunction are the patients that have a preserved ejection fraction, but they don't have adequate volume within the ventricle. So their problem is they have a thick, dense, hypertrophied ventricle, very small ventricular cavity. So again, when they're experiencing ischemia, as what we see with a STEMI or an ST elevation MI, we'll see an increase in that left ventricular filling pressures and decreased myocardial wall compliance. So the ventricle becomes very stiff and the pressures start to increase within the ventricle. When the left ventricle is less distensible, that increases pressure again, decreases stroke volume, and again can cause back pressure leading to pulmonary congestion, hypoxia, and then that will further get reflected back over to the right side, and now the right ventricle has higher pressures because it's pumping into the congested pulmonary system. So the bottom line with that is that we have poor compliance that leads to decreased stroke volume and decreased cardiac output. Now, if we have systolic dysfunction with a patient who develops cardiogenic shock, so again, they experience an ST elevation MI, leading again to the myocyte necrosis, causing poor contractility. If the muscles aren't able to contract properly and those muscles are stretched, we have an increase in the left ventricular end diastolic pressure and volume, but poor contractility, which means we have a low cardiac output, and so then it's going to back up into the left atrium, going to back up into the lungs, and we get the severe pulmonary congestion, hypoxia, and again backing up through the lungs. So the bottom line with a systolic dysfunction is that we get poor contractility and volume overload, which again leads to decreased stroke volume and decreased cardiac output. So two slightly different mechanisms, but the end result is exactly the same. So the hemodynamic summary with a patient then with cardiogenic shock, again we have a decreased cardiac output, we have plenty of volume, so our preload is adequate, and we have lots of vascular tone, so our afterload is typically very high associated with that, and that further causes the heart to fail because it's pumping against such a high pressure and high afterload. So things that we can do to try and optimize the patient who's experiencing cardiogenic shock. When we look at our preload, if we have better volume, then that's going to lead, and better stroke volume, it's going to lead to a better cardiac output. So if they are hypervolemic, so we see this with our congestive heart failure patients, if they have oliguric renal failure and so the kidneys aren't excreting fluid like they should be, or if they have been over-resuscitated and they have excessive fluid administration, we can then look at the use of diuretics, our vasodilators like we described with our heart failure chapter, as far as nitroglycerin and morphine that helps with vasodilatation, decreasing preload and afterload, and decreasing the workload of the heart. If we're trying to optimize our afterload to improve our stroke volume and cardiac output, then if our afterload is too high, so now they're clamped down, if they have pre-existing hypertension, if they have aortic stenosis or other types of increased pressures on the left side of the heart, or we're in the late stages of a hemorrhagic or hypovolemic shock, then they're going to be clamped down and the systemic vascular resistance on the left side is going to be very high. Treatment then, if they're clamped down, then vasodilators would certainly be indicated. If it is an aortic stenosis type picture, then we can look at replacement or repair of the aortic valve if they decide a valvuloplasty. And if it is a late stage shock, then we need to make sure that we're addressing the volume and the shock state itself. If we want to optimize our contractility to help improve our stroke volume and cardiac output, the patients that have that systolic dysfunction, so they've got a poor pump and a reduced ejection fraction less than 40%. This can result from the dilated cardiomyopathies described in heart failure, acute MI, if they have insufficient or regurgitant heart valves. So if they have aortic insufficiency or mitral insufficiency and we get immediate backflow of blood, that's going to impact the overall stroke volume and cardiac output. Or also if they've developed dysynchrony as a result of a bundle branch block or the dilation of that left ventricle. So management for those patients then, if it is a cardiomyopathy, then we'll assess whether or not they would benefit from positive inotrope, which will enhance contractility. Obviously, if it's a ischemic patient, then we need to look at catheterization, possibly stents or angioplasty, or even a bypass surgery to help restore perfusion to the myocardial tissue. Again, if it is leaky valves and regurgitant valves, then we're going to look at valvular surgery to try and repair the native valves, and obviously dysynchrony, then we'll look at the biventricular pacing, and cardiac resynchronization therapy would be indicated. Our next type of shock is obstructive shock, and with obstructive shock, as we said, there's some sort of outflow obstruction. This is a hypodynamic shock state, and whatever that outflow obstruction is what's causing that decrease in cardiac output. It'll lead again to increased filling pressures, impaired ventricular filling, and decreased ventricular compliance because of all the pressure pushing down on the heart and preventing it from filling adequately. Most common causes of an obstructive shock type picture, pericardial tamponade, where fluid is accumulating around the heart, tension pneumothorax, where one of the lungs is deflated and has collapsed, and now I have positive pressure in the thoracic cage, and that will also compress down the heart. An acute PE, a pulmonary embolism, can also be considered a type of obstructive shock. If the clot is large enough to block the pulmonary artery, again, the heart's capable of pumping, but now I have a clot within the circulatory system in the lungs that's preventing volume from moving from the right side to the left side, and that would lead then to an obstructive shock. So treatment is fix whatever the obstruction is. So if it's a pericardial tamponade, then cardiocentesis would be indicated with that. If it's a tension pneumothorax, either a needle decompression emergently or the placement of a large bore chest tube to help restore that negative pleural pressure and allow the lung to re-expand and restore the normal pressure gradients within the thoracic cage. And if it's a PE, then again, treating on whether or not they need an embolectomy or if they can be successfully treated with clot buster like TPA, antithrombolytics, and anticoagulation would be indicated for that patient as well. So with a pericardial tamponade, typically what we will see in this, we'll see distended neck veins in the jugular venous distension. We'll see an increase in their central venous pressure. Pulsus paradoxus, which means we see respiratory variation in their blood pressure. So when they take a deep breath in, their pressure typically will drop, and then as they exhale, their pressure comes back up, and we'll see that exaggerated response. Easiest way to assess for that is by looking at your arterial line, and you'll see that respiratory variation of your art line. As they breathe in, the pressure will come down, and then it comes up as they exhale with that. We'll see a decrease in cardiac output, again, because of that pressure compressing the heart down. So we look at, the Beck's triad, which is that hypotension, and it doesn't improve with a fluid bolus. We'll have muffled heart tones or diminished heart sounds, and that's a very difficult sign to pick up on because you will still hear heart sounds. So again, if you have low blood pressure, you have a mechanism of injury, and you start to see that tachycardia, jugular venous distension, then go ahead and start thinking about a possible tamponade and not wait for the development of muffled heart tones. It's a very late sign, and it's really difficult to pick up on until very late into the process. And again, we want to intervene sooner rather than later. So diagnosis of a pericardial tamponade, then echocardiogram will certainly be able to diagnose that, and we'll see the fluid accumulating around the outside of the heart. They can do a FAST scan, which is a focused assessment with sonography for trauma. So again, they can look at abdominal sources if it's a patient that comes in through the emergency room to see if there's something that's causing fluid accumulation or bleeding versus whether it's in the thoracic cage. Our labs, we will look at our CKs, our creatinine phosphokinases, the chemistry, their coags, chest x-ray, 12-lead EKG to detect any ischemia or arrhythmias, and typically hemodynamic monitoring then is required for these patients to make sure that we've reestablished those normal pressures within the thoracic cage and normal cardiac function. So with pericardial synthesis then, they use echo guidance with that, and so again, once the diagnosis is made, this is an emergent procedure that we need to intervene sooner rather than later. And sometimes they may require oxygenation and ventilatory support. They may also require inotropic support, so it's important that we assess that. And volume expansion is also important to make sure they have adequate volume as needed. So the hemodynamic summary that we see with an obstructive shock is that we see a decreased cardiac output. We have an increase in preload, increase in afterload and vascular tone, but this outward force is causing the patient to not be able to have normal heart function in response to that increase in pressure. Our last type of shock that we're going to discuss is distributive shock. And in this case, we have a maldistribution of our blood volume. So the challenges here is that we have some volume. I've got a good pump, but I have loosey-goosey vessels, so profound vasodilatation, and that's usually pathological. So we usually see this with sepsis, neurogenic shock, anaphylactic shock, adrenal insufficiencies can lead to a distributive shock. That maldistribution, the vasodilatation, means the volume is kind of camped out in the periphery, and they have very low mean arterial pressures, and so then we don't have enough of a pressure gradient for the hemoglobin to drop the oxygen off at the tissue level. They have a refractory hypotension that is not responsive to adequate volume and fluid resuscitation. Oxygen extraction is severely decreased because of that hypoperfusion, because of the decrease in the mean arterial pressure, especially what we see when we have patients that are septic with that. With sepsis specifically, we have a separate module describing sepsis, but the bottom line with sepsis is that they have this massive inflammatory response to infection, and it's not that the body fails from the infection, but they fail from the response and the inflammatory response to the infection with that. So again, distributive shock challenges are typically related to oxygen extraction. When the tissues aren't getting the oxygen that they need, then obviously we move into that anaerobic metabolism and increased production of lactic acid, and they can very quickly progress into a multiple organ dysfunction syndrome with this. So that basically leads to this progressive dysfunction of at least 2 or more organ systems that start to fail. Again, that pro-inflammatory process, such as the systemic inflammatory response syndrome or sepsis, can lead to that, and typically the organs that we see affected by this, the brain, the lungs, our kidneys, hepatobiliary, GI, hematological, as well as cardiovascular, will all see significant compromise in response to the lack of perfusion. The systemic effects of these pro-inflammatory mediators and these cytokines. Cytokines are different chemicals that are released in response to inflammation. So we have cytokines, leukotrienes, bradykinins, histamine, and they all are pro-inflammatory vasodilators. And so we will see this increase in systemic vasodilatation. That will also lead to that increase in capillary permeability, causing a capillary leak. Fluid will move from intravascular to interstitial, and so we start to see that third spacing, and they start to sequester fluid out into the tissues. When the volume is not in the vascular compartment and it's now third spaced out into the tissues, then that impacts the preload coming back to the right side of the heart, and that will overall decrease our stroke volume and decrease our cardiac output and our blood pressure. So then we start to see the hypotension. As the vasodilatation continues, the mean arterial pressure continues to drop, and so as the MAP drops and the vessels become more dilated, then we see that decrease in tissue extraction, and so again causing worsening anaerobic metabolism out in the tissues. Part of inflammation, as we mentioned earlier, causes activation of the coagulation cascade and causing activation of the platelets, and we get platelet aggregation, and that then further decreases perfusion to the organs themselves, and they lead into that multi-organ dysfunction syndrome. Initial resuscitation then that we look at is to utilize for sepsis, especially a protocolized quantitative resuscitation protocol for patients with a sepsis-induced hypotension. Typically, we're going to do fluid challenges. We want to measure their CVP and target a goal of at least 8 to 12 millimeters of mercury of pressure if they're spontaneously breathing. Otherwise, if they're on a ventilator and we have positive pressure ventilation, then we need to target a higher CVP. Our goal is to maintain or achieve a MAP greater than 65 millimeters of mercury, and that will help ensure that we have adequate tissue extraction out in the periphery. Urine output, again, at least half an ml per kg of body weight per hour, indicating that we have adequate perfusion to the kidneys. Possibly looking at SVO2 monitoring or SCVO2. So SCVO2 we want greater than 70%, SVO2 greater than 65%, and recommendations for that will also be described in the tissue oxygenation module. And then again, targeting resuscitation to normalize the lactate for patients that present with sepsis. Antimicrobial therapy, again, that we have appropriate selection, and it's not as much where the patient presents with sepsis, but the severity of their symptoms. So if a patient is already looking like they have septic shock, then we want to make sure that we start antibiotics within 1 hour. If they have the signs and the criteria for sepsis, but they don't have signs of shock yet, then we have up to 3 hours to get the first dose with that. It's important as far as the selection of empiric therapy, and making sure that we are using good antibiotic stewardship so that as the infection is getting under control and there are indications that we can come off the antibiotic, then we certainly need to do that to make sure that we don't create more resistant organisms within that. So the hemodynamic summary then with a septic shock or distributive shock then is early on we have that profound vasodilatation. I have a good pump, some volume, but loosey-goosey vessels. So early on you'll typically see a very high cardiac output with very low resistance on the afterload side. And then you will, and the preload is relatively low in response to the amount of vasodilatation that they have. The challenge there is that the heart can't maintain that type of perfusion for very long, and so eventually the heart's going to poop out and it can't sustain all the catecholamines and very low resistance to support perfusion, and so eventually the heart will start to fail because it can't maintain that high of a workload for very long. So markers of any shock state. So when we're, what do we look for to see is our patients, starting to look like they're becoming, or showing signs of shock. Our lactic acid level. The lactate is one of the most widely utilized labs to determine how well we're oxygenating at the tissue level. So looking at our oxygen consumption and oxygen delivery with that. Normally our lactate should be well below 2 milliequivalents or millimoles with that. So a lactate greater than 2 indicates that they are hypoperfused. Lactate greater than 4 millimoles or milliequivalents indicates that they're typically what we see in a sepsis picture. We can also look at the base deficit. So looking at the ABG, when you look at the base excess or base deficit, if that is a negative number and that number is more negative than -5, so -6, -8, -10, -13, that also is indicative of decreased perfusion and usually related to volume resuscitation is required. So the more negative the number, the more severe the metabolic acidosis, indicating that they need more volume to support perfusion and tissue oxygenation. So things to ask, especially in a critical care environment is, what are we measuring and why? What are we trying to accomplish? Are we measuring just for the sake of measuring, or are we going to actually utilize the data and make it meaningful to help impact our plan of care and our interventions to help best meet the patient's needs? Looking at maintaining tissue oxygenation, one of the scary things about, shock states is that, again, they may not have any outward signs early on that they are not oxygenating adequately. So again, adequacy of tissue oxygenation then is an important tool to be able to determine how much oxygen is being delivered to the tissue and how much oxygen is required to help support aerobic metabolism. And so we do have a separate module talking specifically about tissue oxygenation. Global tissue hypoxia can still be present even though we've normalized their vital signs. So up to 50% of patients that are resuscitated from any type of shock state can still experience global tissue hypoperfusion and anaerobic metabolism even though we've normalized their vital signs and normalized their blood pressure and CVP, central venous pressure. So again, it's more than just normal vital signs. It means we need to have normal tissue oxygenation at the cellular level. And so looking at those lactate levels, the base deficit, SVO2, SCVO2, looking at the whole picture to see have we adequately restored perfusion to the patient. So key points when you're looking at shock states, a mental status change is one of the earliest indicators that the patient is not perfusing and it needs to be investigated. We can still have significant hypoperfusion even though we may have the absence of significant hypotension. So they may still have normal vital signs, but still, normal vital signs doesn't mean normal perfusion. So we need to be looking for other signs that they may not be perfusing adequately. This concludes this module.